very good. Now I would like to invite Dr. Manu SAINI, who is faculty at PGI Chandigarh, and she will be elaborating on graft proficiency and eyelid restoration.
The mic is on, yeah. A very good morning to all present over here, and it's my pleasure to be here. And sincere thanks to Professor Neelam Pushkar ma'am and AIOS for this opportunity. Having laid the foundation of lid reconstruction, now turn to the use of the graft and their proficiency in eyelid restoration. Given the delicate nature of the eyelid, it is essential to understand the fundamental notion regarding the use of the graft in eyelid surgeries. As a basic rule, graft should be used when there is adequate vascular bed to enhance the post-transplant survival, and a full thickness graft larger than a 1/3 of the eyelid require reconstructed in two planes, that is anterior lamella and posterior lamella separately. Considering the two aspects, the association of the two flaps for the construction of both lamella is generally not indicated. So from this point, it could be taken that the use of the two flaps for lid reconstruction seems to be the safest combination in terms of the vascular supply. However, the use of the two flap can cause thick reconstructed eyelid unless exclusively replaced by the missed tissues. So for the same reason, use of flap and graft is the best option for satisfactory aesthetic results. But in case of the severe lamellar loss with limited adjacent tissue availability, what options we have? In such case, bilamellar graft can be reconstructed with orbicularis oculi mobilization between the grafted area known as sandwich flap as described by the Professor Neelam Pushkar ma'am earlier and Kakizaki et al. So this recently published article in OPRS called the question, the long-term belief that intact vascular supply is needed for the graft survival. Here authors used free tarsal graft and free skin graft for lower eyelid reconstruction, virtually no vascular supply. And surprisingly, graft uptake was seen in all the 4 cases. Here authors postulated that survival of the reconstructed eyelid was either due to adequate revascularization of the tarsus and skin graft from the peripheral tissues or nutrient support from the tear film or the combination of the both. However, limited sample size and the reconstruction of the lower lid, which is a small tarsus height as compared to the upper lid, limits its widespread use. Now the next question, why is there a need of graft over the flap? The answer is graft can be employed where adequate myocutaneous flap or vascularized orbicularis flap is not readily available. Additionally, any deformity or asymmetry at the tissue flap side can be eliminated and further add the benefit of the one-stage procedure. Eliminate prolonged visual excess occlusion, especially in elderly populations where it could be quite disabling and place the patient at risk for ambulatory instability and self-injuries. Many of the flaps are not suitable due to previous eyelid surgery, require revision, and poor candidates for perilesional flap dissection. A few words about the surgical anatomy for better understanding. The upper lid and lower eyelid are composed of analogous structures that are divided into the anterior lamella, middle lamella, and posterior lamella. Anterior lamella includes skin, orbicularis oculi. Middle lamella refers to the retractors of the eyelid and orbital septum, and posterior lamella refers to the tarsus and the conjunctiva. The involvement of the anterior lamella and posterior lamella leads to ectropion and entropion respectively, whereas middle lamella involvement will produce the posterior displacement of the orbital fat pad, hollowing appearance and retraction of the lower lid or upper lid, resulting in scleral show. It can be tested by vertical traction test by pushing the lid upward, and any resistance to the movement suggests middle lamellar scarring. Now coming to the scenario-based discussion. An essential concept for the graft, regardless of the lamella involved, is the principle of like for like. Like in this, a young patient who present with upper lid cicatricial ectropion and localized notch underwent full thickness skin graft. Sorry. Ideal donor sites for the skin graft includes upper lid, lower lid skin, or the contralateral eyelid. In absence of eyelid harvesting, the different sites which can be used are the posterior auricular, preauricular, or supraclavicular regions. Split thickness skin graft is used in case of the extensive burn with limited donor site availability. Pay attention to the immobilization of the graft as much as possible to prevent shearing forces induced compromised vascular supply to the graft. Now coming to the posterior lamellar augmentation, an intact tarsus is essential to provide support to the lid and to prevent a contracture following reconstruction. So posterior lamellar shortening can be augmented by using the tarsoconjunctival substitutes. Various autografts are available that should be preferred over the allograft. However, allograft can be promising posterior lamellar substitutes due to reduced surgical time and no donor site sequelae. Example is scleral segment. This young patient shows a case of severe cicatricial ectropion with leg ophthalmos showing the thickening of upper lid, suggesting the diffuse involvement of lid. Most of the minor to moderate cases can be managed with the mobilization of the local flap. However, the large involvement or the diffuse involvement require a full thickness or sometimes a posterior lamellar augmentation. Now, what options we can have? As it has been already discussed by the Dr. Mradula ma'am, I'm quickly running. We have the contralateral tarsus, which is an ideal substitute, but the main disadvantage is limited resectable graft size without destroying the function and aesthetic of the donor side. According to the study, it is safe to preserve the 4 mm adjacent tarsus to the eyelid margin and remove at most 17 mm in length and 6 to 7 mm in height. The other one we have is a hard palate graft, which is similar to the tarsoconjunctiva in terms of the collagen fiber structure and density. It is resistant to deformation and readily acquire or conform to the shape of the eyeball. But the disadvantage is the stratum corneum that may cause the friction against the cornea, and it is thick to process and take longer time to epithelize. Moreover, donor size, hemorrhage and pain are the threatened complications. The next one in the list is a buccal mucosal graft, which is harvested from the lip or cheek and used to replace the posterior lamella of upper eyelid. However, it lacks the structural integrity. It's too weak and small to support the lower eyelid. For lower eyelid, we can have the options of auricular cartilage that provide the favorable results because of relative ease of harvesting. But at the same time, displacement, detachment, warping, downgauge disturbances are some of the potential complications. Dermis pad graft can provide an additional scaffold, and the rarest of the graft we can use in absence of all the available options are not available. Then we have gallia or pericranium, which should be used or can be used in severe periocular trauma cases, wide tumor resection or socket reconstruction, especially in collaboration with the neurosurgeons. Now a short video of the same patient where posterior lamellar augmentation was done using MMG. Oral mucosa is a preferred choice for posterior lamellar augmentation because it has a low stage of differentiation than epidermal keratocytes. It has a short cell turnover time and the resultant scar is inconspicuous. Moreover, the keratin 3, which is considered as a reliable marker for corneal differentiation, is also positive in case of oral mucosa. After debulking the MMG, it is placed over the lid. The superior edges are secured using the 6O or 8-on vicryl in a continuous manner. An inferior edge is secured to the tarsus using matrix sutures. 3 or 4 matrix sutures can be used. The post-operative photograph of the same patient showing well uptake of MMG and resolved leg ophthalmos and lid lag, as well as entropion. Now coming to the posterior lamellar involvement, middle lamellar involvement. The middle lamellar involvement will manifest as a retraction of the lid, resulting in exposure keratopathy and leg ophthalmos, requiring spacer graft that need to be inserted between the tarsus and recessed retractors. The various materials has been described and used for middle lamellar augmentation. For upper lid, like in this case, MMG was used as a spacer because it is thin, flexible, non-keratinized, and do not hamper the blink movement trajectory of the eyelid. However, in the literature, it has been described that it is more suitable for mild to moderate cases. MMG is secured to the tarsus and superiorly secured to the recess retractor. The graft should be uniform in width. And finally, lid closure after passing a bite through MMG, which will provide a lid grease. Whereas for the lower lid, you require a graft which is stud that keep the retractors recessed and support the tarsus in upright position. So here, the graft should be biocompatible, easily available, have low rate of the contracture, should have some degree of the stiffness to provide the support, and should promote tissue integration with minimal inflammation and allow mucosalization of the conjunctival side. In this case, retroauricular cartilage was used. I am skipping because it has been already described by the Neelam ma'am. Precise and the gentle dissection. Full thickness cartilage is harvested and a mashing is done to facilitate the contouring and follow the curvature of the eyeball and eyelid. 360 degree, it is secured using the 6-0 Vicryl. And finally, fibrin glue is used to adhere to the underlying pad, followed by skin closure. So to conclude, graft can also be used in irradiated tissues if needed. These type of the grafts generally need to be associated with the local flap to enhance vascularization and guarantee graft survival. The main objective of the surgery include the post-surgical outcome that reflect the normal eyelid in terms of anatomy, aesthetic and function. The choice of the surgery depend upon the several factors including preference, experience of the surgeon, etiology of the eyelid defect, availability of the flap and the graft, and quality of the local tissue can sometimes also modify our choices. Thank you for patience listening.
Thank you, Dr. Manu, for a nice presentation.